Now, I have the honor and the privilege to present the last speaker of this session, Professor Jonathan Ramsay. He's a consultant urologist specialized in male fertility, and his topic will be, is it a significant factor, the sperm DNA fragmentation? Professor, you have the floor.
Well, thank you all, and thank you for the invitation. It is extremely nice to be here to have a conversation about a difficult and interesting subject. The first slide gives a little bit of history because George Christopoulos and I first met at Hammersmith. That's the little insignia up at the top left. And I now understand why George left London and came back here. And then I retired from Hammersmith and have an academic visiting position in the University of Ulster. Now that's important because Ulster is the home of sperm comet single-cell gel electrophoresis tests. And now I'm in private practice, and that's important because that allows me to interact for the first time with many different clinics and colleagues all over London, and I'm pleased to say, all over the world. And it's that breadth of practice that allows one to explore difficult concepts. Now, of course, the last speaker explained why urologists and surgeons should really stick to endoscopy and surgery because it works. But as soon as we, particularly urologists, start voyaging into science, it's very tricky territory. And no more tricky than with sperm DNA fragmentation, because it's been debated ever since it was first introduced. And we know that there are at least 5 methods of looking at the fragmented DNA in a sperm head. And to a certain extent, I think one of the reasons that we don't universally accept it is because this test was developed by scientists, not clinicians. And scientists, of course, have a tendency to argue about the way they do their test, because their test must be the best test. And so almost throughout the genesis of the different ways of measuring DNA fragmentation, particularly Don Everson in America and Sheena Lewis in Northern Ireland, argued heatedly about which was the best test. And people like me, clinicians, began to get the view that if the scientists were arguing about which was the best, then possibly none of them were any good. But all of those previously mentioned tests were concentrating on single-strand damage. And of course, single-strand DNA breakage is happening everywhere in our bodies. The more active biologically and metabolically the tissue, the more breakages they are, and they are constantly being repaired, and indeed can probably be repaired by a young, competent egg after fertilization. Double-strand breakage, however, is different. And the tolerance of double-strand breakage in the sperm head is pretty tight, less than 6%. So we're immediately beginning to get a simplistic view that if single-strand breakage is happening all the time, and the tolerance may be 15% as measured by a fragmentation index, maybe up to 30% when measured as an average with single-strand breakage, then if the tolerance is only 6% in double-strand breakage, could not that be a better test? So if we review where we are with single-strand breakage, I think that these comments are not contentious. We associate single-strand breakage with oxidative stress, and we know that particularly lifestyle and some antioxidants will be effective, and I excitedly await seeing more and more obese men who have used Mounjaro and Ozempic, because I think that is already having, by observation, a very significant effect on fertility. The guidelines for treating varicocele, even in the backward old UK with NICE, are being revisited. And so I think most urologists would agree that varicoceles larger than 3 millimeters with reflux flow do have an effect on male infertility via probably oxidative stress, and therefore there is single-strand DNA breakage. And I was very interested to hear about the microbiome in the endometrium. We didn't touch much on the microbiome in the vagina, but I am a believer that the seminal plasma microbiome must have an inflammatory effect and may even be the cause in some men of that impossible to treat condition, chronic abacterial prostatitis. Because of course, it was probably never abacterial. We go off down a rabbit hole. It's one of my enthusiasms. We used to treat these poor men for weeks and weeks with ciprofloxacin, and they were a bit better because, of course, quinolones are slightly anti-inflammatory. But when you stopped the quinolone, the symptoms came back with a vengeance. I think we were merely altering the microbiome. Certainly with male accessory gland infection, we get measurable increased DNA damage, which recovers when you treat it. So the single-strand break, the much-debated single-strand break, we do often find it in unexpected male infertility. And we do treat the oxidative stress, and we do improve DNA fragmentation. And probably there are improved fertility outcomes. This is, I think, almost difficult to prove. And I often think to myself, and infrequently say to colleagues, as soon as a fertility expert uses the word evidence, stop listening. So the Global Andrology Forum, started by Ashok Agarwal at the Cleveland Clinic, has about 900 members. And what Ashok has cleverly done is to do a lot of consensus work to see what actually happens. And of course, what actually happens with urologists, gynecologists treating men, andrologists from whatever stem, what actually happens is that they do take notice of ordinary DNA fragmentation, and they do treat for oxidative stress, and they do take these matters seriously before actually making a straightforward onward referral for IVF, ART, or ICSI. So I think with single-strand breakage, we can, I believe, we can improve outcomes by improving the quality of the sperm, and here's the significant bit where I think all of you in this room have probably been right all along, which is that better sperm selection may well be selecting those sperm with better fragmentation, and thus we get better outcomes. This was an AUA poster looking perhaps further down the track at outcomes, but I want to stress that what was being measured here was single-strand DNA breakage. And we must now think about whether this single-strand breakage has a deeper or surrogate significance. Because of that statement, why can't we prove this. I think it may be because with single-strand breakage, we're not really measuring the right thing. Because, of course, single-strand breakage may be masking a much more significant phenomenon, which is double-strand breakage. And that slide made the point about the 6% cutoff versus the 30%. If you think about medical tests in general, where there is a huge range, as there is for single-strand, normal in inverted commas, single-strand DNA breakage, ranging from maybe 12, 13, 15%, right up to 30%. When there's a large range in a medical test, it's often not a very good test. But when there's a tight range, we may be looking at something which is at last significant. And so double-strand breakage is probably mostly occurring during the spermatogenic process. And of course, the spermatogenic process, there are three main stages where it may be subject to epigenetic damage. And I think we are therefore, this is for conversation, yeah, this is the collected thoughts of an old urologist. So I think this double-strand breakage is underlying both unexplained infertility and idiopathic male fertility, and there may well be an epigenetic phenomenon at work. This is about the occurrence of the testicular dysgenesis syndrome, first noticed in Northern Europe, where it was seen that the incidence of testicular cancer was rising quickly, and in fact, that rise in young men was mirrored by a rise in subfertility. And in fact also, other markers of an endocrine disruption during fetal life and during adolescence were also evident in these men. A reduction in anogenital length and various degrees of hypospadias. And of course, hypospadias is quite difficult to detect because the smallest degree, the glandular hypospadias, is often a little dimple at the end of the glans penis, and it looks as though the urethra is opening in the normal place, but actually it isn't. And so all these features which could come together as due to endocrine disruption and a failure of proper spermatogenesis were occurring and first noticed to be occurring in the late 70s and early 80s. But it has taken us a very long time to agree that worldwide sperm counts, which may be a mild feature of what is on this slide, sperm counts worldwide have declined by 50%. Now, governments don't want to talk about this, healthcare organizations don't want to talk about it, because it's all very uncomfortable. As we know in this room, there is a preference for politicians, particularly, and healthcare providers, to say that if the fecundity rate, the fertility rate is falling, this is all due to economics. They prefer that because, of course, economists like to fix things economically. But actually, the observation is that in countries who have tried to reverse that trend, Hungary, New Zealand, by offering economic financial solutions to young couples to start their families earlier, actually, it hasn't worked. So I believe that what is happening on that picture is as significant as is economics on world fertility rates. So what about this double-strand breakage? If it is the case that the single-strand markers were hiding the double-strand, let's look to see what happens in men who have only double-strand breakage. And this is quite compelling, because for the first time, there is a significant difference between the red line, of course, the red and the blue line are running in parallel because of female age. But there is a significant difference in overall fertility. So I think, and it's for conversation, this double-strand breakage is relevant. And if it's relevant to the way in which spermatogenesis is happening and the way in which the testicles developed, then it may be the clue to these observations. And the observation on the left side, reported in ESHRE this year, is extremely compelling. The Danish healthcare system, as I'm sure most of you know, is almost unique in that the equivalent of the health service number, registration, is the same as the national insurance or national identity number. So therefore, it is one of the countries where outcomes can be tracked. So you can track the fact that a man has ever had a semen analysis, and you can follow the medical and surgical interventions, and indeed his overall longevity thereafter. And this was a very compelling study. Of course, the gainsayers, because we've always got gainsayers here, like climate deniers, they immediately said, oh, well, this isn't true because Denmark is a socialist country and these men were all poor and socially disadvantaged. You know, typical nonsense. But then we get the same data from American health maintenance organizations where the driver to record every medical event is purely financial. And that data shows precisely the same relationship between infertility, or the measurement, the proposition of subfertility and abnormal semen analysis, and future health outcomes. So, what is out there? There aren't any meta-analyses, I'm delighted to say, but the Hewitt Centre in Liverpool reported in several hundred couples with recurrent pregnancy loss a 60% association between double-strand breakage and more than 2 or 3, I think, early pregnancy losses in 1 year in young couples. And this is a very interesting, as yet unpublished observation from 3 fertility centres, including a big fertility centre where the well-known urologist Esteves works. And this is pretty compelling data. If this is proven or becomes accepted, then at last we have a decent marker of male fertility. And of course, the use of the zymote was first described some years ago in double-strand breakage by my friend Jordi Ribes-Mainu in Barcelona. And he showed, I think quite convincingly, that double-strand broken sperm were deselected on one side of the 850, not the 850 microliter zymote, I think he was using the 20 microliter zymote. And of course, this would explain why ordinary sperm selection techniques in ICSI are favoring men who have single-strand breakage rather than double. So it may well be right that if you only have single-strand breakage, as most of my urological colleagues have always said, ICSI techniques and sperm selection sorts it out. I don't believe that it completely sorts it out. I think you can make it better by treating the things that we've mentioned. But if the overall single-strand breakage is masking the double-strand breakage, then of course it may well be that the more significant thing is the double-strand breakage, and that is what the zymote is selecting. So this is merely the reports from This is, crikey. Is that really me? I'm not sure. But this is the draft paper to which I was referring, which I think will be published quite soon. We discussed the epigenetics of the possibility of double-strand breakage, and there's one other practical consideration here, and this is my own view, which is that when all else has seemed to fail, and we're all grasping for something else to do, like a surgical sperm retrieval, often very attractive to the poor patients who are now on their 4th or 5th cycle, and somebody says to them, we know what to do, we'll take the sperm surgically from the testicles. That'll fix it. Well, it won't fix it if it's double-strand breakage, because that's where the genesis, the origin of the problem is. So in my practice, I limit surgical sperm retrieval as a last resort in failed cycles to when it seems clinically the case that something in the genital tract is damaging the sperm, but the patients do not have double-strand breakage. Now, we can either do some clinical cases or not, because I can rest there because I'm well aware that we're out of time. So tell me what you would like me to do.
Well, we are behind schedule.
Yes.
Half an hour.
Yes.
How many cases studied?
There are 4 of them.
Lasting about each?
I can do them in 1 minute each.
All right.
This is an outpatient clinic. Yeah?
Yeah.
I've got to get home to dinner. Right, here we go. The first patient, yep. We've met young couples who don't do very well, and you must just cast your eyes along the bottom bar there if you can see it from the back. So the point about this is that here's a young man, his total motile count is just fine, and so the question is, why have they done so badly after 4 cycles of ICSI? Yeah? Now there could be a whole load of reasons, and all of this could of course, be gynecological. But we would all say, well, crikey, this young couple should have conceived naturally. And when we look at their single-strand breakage, so this is the alkali comet test, it's pretty normal, an average of 32. You know, this isn't, you'd be saying young couple should have had a baby. But then when you look at the double-strand breakage, it's high. So this is typical of near normal semen analysis, a bad biological story, single-strand breakage, which is okay, but then we start doing ICSI and it doesn't work. So this is where we are. And with the high double-strand breakage, we would be thinking better sperm selection, possibly the zymote, but measure the double-strand breakage on the other side. And if this goes on forever, don't get to the point of donor eggs, because they're not going to work with high double-strand breakage. PGTA, I won't voyage into gynecological history. Here's another one. We meet these people quite often. This was a young female doctor, actually, and fortunately the older man wasn't also a doctor. But they should have done better, because despite his age, actually, 46 million, 52% motile, 4% normal, they really should have done better after 5 cycles. And there are those chemical pregnancies. Could that be a sperm-related phenomenon? And so when we look at his DNA fragmentation, single strand, again, it's pretty good. If you look at the histogram curves, the majority of his sperm is good quality, even at his age. But when you look at the double-strand breakage, this is not good. And I think, this is for discussion, yeah, no meta-analyses, I think this is telling a story, because she's had well, 30 eggs, 5 cycles, perhaps they haven't done so well. You know, there could be a female factor. But only 3 blastocysts and 1 chemical pregnancy, it's really not good. So once again, can we better select the sperm and measure it? Should we be thinking in this young woman with this older man and bad sperm, should we be thinking of donor sperm? And should we always be doing PGTA? And so here's an older couple. Now this is important because here come the donor eggs. These figures, that bar at the bottom, is about 26 donor eggs from a 25-year-old woman. And it really shouldn't have been that bad. It really shouldn't. And here's the DNA fragmentation, single strand, it's fine. But you see, how much does a 27% average damage per sperm single strand actually mask a maximum of 6% double strand? Well, the answer is quite a lot. This is differently reported because this is when we were doing the test in the context of research. And so this was the neutral COMET test, and there is the average COMET score, as it was then told, of 11%, almost double the upper limit of normal. So there we are. I think I'll leave it there, because otherwise it's all the same, isn't it? It's one failed cycle after another. It'll drive us all bonkers. Thank you very much.
Thank you very much, Professor. We really enjoyed your speech.